I wanted to introduce our speakers today. First, as part of the CME criteria, please be aware this is a CME accredited event. There are no commercial sponsors of the spring rounds. Disclosures were reviewed and no conflicts of interest were found. And then to introduce our speakers, Richard D'Aquila, FACHE, is the president of at Yale New Haven Hospital and Yale New Haven Health System in New Haven, Connecticut. He's responsible for all day-to-day operations of the hospital and all aspects of its performance as a destination medical center. His responsibilities also include the development and execution of clinical strategies and ambulatory services around the Yale New Haven Health System and its network partners. Tom Balcezak, MD, MPH, is Chief Medical Officer of Yale New Haven Hospital and Yale New Haven Health System. He joined the hospital in 1992 and has hospital and health system oversight responsibility for medical staff affairs, graduate medical education, patient safety and clinical quality, accreditation and regulatory affairs, clinical redesign activities, and care management.
Thank you. Good morning. Good morning, everybody. I'm sorry we subjected you to that overview of our job descriptions. Tom and I are doing this in every clinical department, every clinical service, and the thought process is to really talk about the state of the hospital, give you an update of where we are in both the hospital and the health system. But what we really want to accomplish is a dialogue about what you want to hear more about. We have 4 or 5 slides. We're going to do a quick overview. I'm going to talk about where we are so far in our calendar and our fiscal year 2018. And Tom's going to focus on a couple of areas that are specifically important around our work around high reliability and physician engagement. And we're going to do that in about 20 or 25 minutes. Really, the rest of the time is to hear what you want to hear more about, or anything that we've touched on that we want to have more discussion on. I have very few data slides. In general, we are in a very difficult and challenging environment, bucking a lot of the trends. Yale New Haven continues to be strong on virtually all operating fronts. It's a real challenge in the environment that we're in, and we'll talk about some of those challenges. There are just a couple of data slides here, and they really give a snapshot, we think, of 4 critical dimensions of performance. Kind of step back and think about the numbers that matter. What we try to convey in the data are how are we doing in our focus on high reliability and eliminating events of harm. How are we doing with patient experience and patient satisfaction? I'm going to talk about each of these. How are we doing in the work to continue to grow and build our presence and the strength of our programs, and then how are we paying for all of it to the extent that we generate an operating margin that can support the kind of investments in growth and development. Of all these data, Tom and I are most proud of what's in the top left quadrant, and that is, it's tough to see, but these data points each are 12 months of cumulative events of harm, serious safety events, things that happened to patients that were unintended, and these are the numbers. This is the number that our focus on high reliability is trying to drive to 0. These slides are old. Actually, the latest number is 19. Tom will talk more about that. And we've gone back to 2014 here because that's when the focused, deliberate efforts around high reliability started. I want to really emphasize the number 19 is still 19 patients too many over a 12-month period, but you have to frame it in the context of how busy we are and how, as an organization, how many patients we take care of. That is 400,000 patient days, nearly 1 million for ambulatory visits, 80,000 discharges. Again, that's just the end. And driving this number to 0 is an extraordinary challenge, and not something that we're ever going to take our eye off as an organization. But directionally wanted you to see the kind of progress that you're all making, and why this number and this whole effort is so critically important. The rest of the data, patient experience, I'm not going to spend a lot of time on this. This is really a mixed bag, and these data just show the averages. What is in orange is our patient satisfaction trends in outpatient care. What's in dark blue are the trends that are inpatient, and what is light green is the emergency department. A lot of this is struggling, and we'll talk about it later, struggling under the impact of crowding, patient volume, a mixed bag. I'll describe that in greater detail in a minute. And the whole experience that patients have when they come to the hospital through one of two tracks. When they come to the hospital through an elective scheduled process, our patient experience is almost uniformly extraordinarily high. When they come through the emergency department and they wait 15 hours for a bed, or they end up in a hallway, or they end up in a 3-bedded room in the East Pavilion, it's a whole different story, as you can imagine. And we can talk about some of the efforts to focus on that. You know, the last thing about these data that is important to note is we have some services and departments that are in the top 4th or 5th percentile. They are class leaders. We have others that are in the bottom quartile. We're all over the place, and a lot of the work here really focuses on being very deliberate around communication, the environment, the things that are really important to patients, and the averages don't really tell that story. I'm going to skip volume because I have a slide in a minute that puts a fine point on it. But there's been a very deliberate effort to grow our service lines, our service volumes, our geographic expansion, and I'll show you an example in the next slide of what that has created in terms of momentum around volume. And the last slide is our operating performance financially for year-to-date 2018. We are having another year when our revenues are exceeding our expenses. And you know, these data are, and I use the term margin deliberately instead of profit. We are a nonprofit institution. Whatever we generate in terms of operating margin gets invested back into programs and people and technology. And I'll give examples of that in a minute. But it's important to really reinforce that when you hear the term profit, or when you hear the term that the hospital is profitable, you know, that is a pretty serious mischaracterization for us. We invest every bit of operating margin back into the hospital in the areas that I described, and that's kind of the lifeblood of what allows us to move forward as an organization. It's an important distinction that because we are a nonprofit and we're a safety net hospital, we take care of patients regardless of ability to pay. It's our operating margin that makes that possible. I mentioned volume. These data also are kind of pre-flu data, and they show the momentum of what continues to be a very busy and growing hospital. And this is very deliberate, and it is contrary to what's going on out there. Most of what is happening in Connecticut is shrinking, and we're really deliberately focused on not doing that. So a couple of things have happened here. One is the efforts to be a transfer center, to take the sickest patients that other hospitals can't handle, to work around Y-axis, has produced a very, very significant impact on our volume. We, on any given day, so we get, when Y-axis, which is now about 4 years old, is up to nearly 700 transfers a month to Yale New Haven. These are patients from anywhere, regardless of their insurance coverage, who are transferred to us because they can't be cared for in institutions. they're in. We deliberately cultivate that. We work hard to take those patients and really carve out that niche for ourselves as a tertiary and quaternary facility. It's actually proven to be a tremendous growth strategy. These patients have grown to a point where on any given day, in our 1,400 occupied beds, nearly 200 patients are Y-access patients. It's actually the single biggest cadre of patients that we have. It's changed the acuity of the institution, where you can see the case mix index has grown, and it's grown dramatically if you take it back to 2011. And again, it's really has been a big part of balancing the fact that reimbursement is shrinking, but it is easier to mitigate that when you're in a growth mode and you're not in a retrenchment mode. So there's a lot that this has done for us on the positive side. On the challenging side, it's put extraordinary pressure on our facilities. Even before the impact of the flu in January and February, we're struggling with occupancy just under 90%. And if you couple that with the challenges of 3-bedded rooms and semi-private rooms, it's created a series of issues that have really pushed us to accelerate plans to plan the replacement of the East Pavilion and the upgrade of the South Pavilion, and I can talk about that in our Q&A. So where do we invest margin? And I want to use this to kind of really underscore the comments earlier about our operating margin. This is what we invested in growth in 2017. I'll show you 18 in a minute. Employees, programs, facilities, significant investment in information technology and technology in general, and other capital. So, and you'll notice the number is bigger than our operating margin, and that is because there's always a gap between what our margin covers and the balance is borrowed or funded internally. 2018 is a growth budget, is a growth strategy for the hospital and in concert with Yale Medicine. I'm not going to go through these individual areas. I think what I just want to leave you with is that we continue to advance in a very deliberate way our service lines, our clinical programs, our ambulatory strategy, new areas like the Center for Genomic Health, and continued commitments in technology and equipment. If you've been on the St. Raphael's campus, a nearly complete upgrade of all of the technology, interventional labs, CT, MRI, a new surgical facility under construction on this campus, the recent opening of a brand new neonatal intensive care unit that is, I really believe, is one of a kind. Those are really significant investments, and that's the kind of stuff we fund when we're still growing and we're able to balance revenues and expenses. Let me kind of end with what we can talk about later. So what can go wrong? Plenty. We are, we're in a very difficult reimbursement environment across the board. Nearly more than half of our patients are Medicare and Medicaid. Tremendous challenges in the state budget in Connecticut and how that is ratcheting back on Medicaid and federal cuts around Medicare. Neither of those payers pay us anywhere near 100% of our costs. And that really pushes us to shift the unfunded component to managed care organizations and the other payers, and creates this whole cost shift set of challenges. But the prospects of reimbursement getting better are dim. So you kind of step back and think about it. These are sicker patients. The technology is more expensive. The people element is more expensive. And the folks who are paying the bills are for both the hospital and physicians kind of ratcheting back. And they're particularly aggressive against academic medical centers like ours that are inherently more expensive. And that just adds to the set of challenges. Connecticut is how's the landscape changing in Connecticut? One of the biggest changes in Connecticut is the stuff that is leaving the hospitals and moving to private facilities. Connecticut has a pro-ambulatory, physician-owned facility stance in its regulatory system. So what we're seeing are a lot of physician-owned surgery centers and outpatient facilities, and that is moving patients out of the hospital, almost all of which have insurance, and leaving us as the safety net. And so that's a particular hurdle in Connecticut that affects us in a negative way. Federal and state political environment is challenging and changing, but again, it's what's playing out in Washington and what's playing out in Harvard in a financially challenged state and a very confused federal situation. We're doing a lot of work to integrate our health system. We can talk about this in Q&A, but very deliberately, the clinical programs and services at Bridgeport, at Greenwich, at Lawrence Memorial, at Westerly are being driven by the service lines and the clinical leadership at Yale New Haven. And Pete can talk about the work that is playing out across the system to really have a much higher level of integration and program and physician relationships. And then just the balancing act. I alluded to this. We are a very unique institution as an academic medical center, but juggling the clinical mission, the academic mission, the community mission with the cost and payment pressures that are out there is something that makes our operating environment very, very unique. So yeah, that's my overview. I'm going to turn it over to Tom to touch on a couple of areas, and then we can open it up for discussion.
Thank you, Rick, and good morning, everyone. So Rick and I really appreciate you taking the time out of your conference schedules to spend some time with us. We think it's really important to get out in front of the departments. This is our second year of doing this, and we've really modeled what we're doing after what the dean has done for many years when he's come and given the state of the school talks. So in our talk is very much going to be foreshortened. I only have 2 slides. I only want to spend a few minutes on a couple of points I'd like to raise with you. And then, as Rick said, we really like to engage in some dialogue. We really want to hear the questions. We have very limited amount of time, really, where we actually are able to spend time face-to-face with all of you and with all of the departments. So we're trying to use these as an opportunity to give you time to ask questions or engage in some dialogue that you otherwise may not have an opportunity to do so. So Rick mentioned in that upper left panel in that first slide that he showed our high reliability work around safety and what's happened over the last 4 years in this organization and how we've really shaped a high reliability culture with an intent, among others, to drive down our serious safety events to 0. And so this has been a very deliberate effort of ours across the health system to really reduce to 0 the number of serious safety events that happen in our organization, because that's really the floor of what's important for us to deliver to patients when they come and seek care with all of us. No one expects to walk away from this organization with a harm event, a fall with fracture, a wrong site surgery, a retained foreign object after a case, a surgical site infection. Everyone expects when they come here, they're coming here to get their life improved, to be somehow helped by their care and not harmed. And that's really, I think, the baseline that we should be aiming for. And then aspirationally to improve their lives and ultimately to expect that that we give them a great experience from the time they meet the ProPark guys until the time that they're discharged. And so what you saw on that first slide was when we began these efforts now 4 years ago, we had about 100 serious safety events per 12-month period. And as Rick mentioned, as of this month, we have had 19 in the previous 12 months. A pretty remarkable reduction, an over 80% reduction of our serious safety events. At the time this slide was created and the time that that first panel was created, we had 24 SSEs or serious safety events in the previous 12 months. Just so we're all talking from the same book and we all are understanding it the same way, our definition of a serious safety event is when an event of harm reaches the patient and then it deviates somehow that care plan for that patient in some way that's meaningful. So we call that minimal, at least minimal temporary harm. So an example that I would use is if a patient gets a drug and requires an increased level of observation, so they have to move to the ICU, or they're an outside patient in the outpatient setting and they need to be admitted, that's considered a harm event. And so when we have those, we count those, we do the root cause analysis, we put in our corrective action plan, and you've seen the resulting changes. A lot of what you've seen in terms of changes in the organization with order sets and policies and practice have really been driven by the history of our serious safety events over the last couple of years. One level below that in this pyramid are what is called PSEs or precursor safety events. This and the one below it, NME, near miss, they're often mischaracterized and confused with one another. We often hear that there is a near miss, which is the bottom one. And those near misses that are sometimes, I think, mischaracterized have a very clear definition in our patient safety staff's mind. A near miss event is when an event of harm does not reach the patient. That means that someone along the line stopped and was able to prevent that medication event or some other error from hitting the patient. Precursor events are when something touched the patient, but the patient wasn't necessarily harmed. So for example, if a wrong medication is ordered or a medication is ordered on the wrong patient and it gets to the patient, but the patient suffers no ill event, that is a precursor safety event. Because while the patient may not have experienced harm, the potential for harm existed. So we have our staff classify all of these events. We get about 30,000 events submitted to us per 12-month period. 30,000, they come in mostly through RL, the event reporter that's on the hospital intranet. And you can see we classify about 16,000 of these as safety events. The other 15,000 or 14,000 are silly things. I don't like Rick DeQuilla's tie or something like that. And we exclude those. But we classify all 30,000 of these events into one of these three buckets. And as we've talked about, the SSE number has been dropping. And if you read the hospital bulletin, or if you're a hospital employee, you know that over the last 4 years, we have incentivized our employees to try to increase the reporting of both PSEs and NMEs. Understanding that as we reduce the number of SSEs, serious safety events, the way we are going to continue to close the holes in the Swiss cheese, if you're familiar with James Reason's model of error prevention, is to understand how those events of harm are reaching the patient in PSEs, independent of whether they're causing harm or not, and how we are also putting strong barriers in the near-miss events to make sure that those events of harm don't reach the patient. So as Rick mentioned, this work, I think, has broad applicability to other parts of what we do. We're actually bringing the high reliability work, believe it or not, to finance and to how we put out together operations, because the principles of high reliability with resilience and transparency and so forth, I think has broad applicability. And I think we've demonstrated here and across the health system that it's actually done, I think, good things for our patients and our staff and our community. Shifting a little bit, there are another sets of focuses around our safety and quality work. I could go into some detail about how we're evaluating our events, the other events, the patient safety and adverse events composite score that's reported to Medicare. We have a hospital-wide mortality review run by Al Friedman, who's a pediatric cardiologist, where we look at every death in this organization and see if there are opportunities to improve our care. We have about 2.5 deaths a day in our institution. We've had some dedicated efforts, and many of you in this room have been associated with the improvement efforts around reducing DVT, PE, CAUTI, C. diff, and so forth. We take the same approach to this work as we have to our serious safety event reduction work. Shifting gears, and this is my last slide, another very important set of work, I think, in this organization, something I hope that's important to all of you, it's certainly very important to me, is focusing on how it is to live life as a physician in this organization. We know that there's a national epidemic of burnout that is also here. Interestingly enough, and if you've read the literature, you know that burnout especially and almost unfortunately affects physicians in the middle parts of their career more so than the beginning and the end of physicians' career. So when physicians are in the most productive years between the ages of 40 and 70 is when the highest risk of burnout is. There's lots of things that we've been working on over the past couple years to try to improve both physician engagement, reduce physician burnout, improve physician wellness. I can get into some detail about this if there's some interest. We have now joined forces with a committee that's recently been chartered by the dean to put together our physician wellness and burnout work, led on the hospital side by Joni Hansen, who's ex-president of the medical staff, and Sandeep Mukherjee, who is a university cardiologist. And on the university side, the dean recently announced a couple of leaders, Naftali Kaminsky and Eve Colson, who are going to be leading that work to try to put together a set of projects to try to both improve our workflow, but also create more of a sense of community within the organizations. So as promised, Rick and I would just at this point like to stop presenting to you, talking at you, and ask if there are things that you'd like us to address or questions that you might have for us.
Howdy and collapsing, and just basically how we're going to attack that, because I think that's another area that's important. Pat, I know, probably can chime into.
So Pete mentioned Vizient. Vizient is the combined organization, BHA, which is a supply chain company and a quality metric company, combined forces, about a year and a half ago with the University Health System Consortium. That's a consortium of the academic medical centers in the United States. All 150 academic medical centers had historically belonged to the UHC, the University Health System Consortium. We were members too. All of us who are members of UHC had historically sent all of our data, all of our discharge data, all of our quality data to UHC. And now in conjunction with VHA, that Vizient now data set is a very robust set of data where we are able to compare to our peers. There are 5,000 hospitals in the United States. There are 150 academic medical centers. So when you are looking at data, when we are all looking at data to compare us to the rest of the hospitals in the United States, it's really not a fair comparison, because the 150 of us academic medical centers are comparing against these hospitals in the United States. The vast majority of them have 100 or fewer beds. So it's really the Vizient data set that we focus a lot on, because we think they've got a really, I think they've got a robust risk stratification methodology, number one. Number two, we all voluntarily give all payer data. There is no other all payer data set in the United States. All other publicly reported measures use the publicly reported and publicly available data set. That's Medicare data. So you've already just created a different group of individuals. And then we also are able to, we also sign an agreement where we're able to share that. So that's a very long-winded way of saying it's a very robust data set. It's a way to compare ourselves to our peers. And every year in September, there's an annual conference where Vizient puts out their quality and accountability report card, and they give a balanced scorecard on that. Some of the data is, as Pete talked about, some of our infection prevention data, because the best infection prevention data is through the Center for Disease Control. We report our data to them as well as to Vizient, and we compare ourselves there. If you look in the medical staff bulletin every month, I put the number of infections in the previous 12 months for each one of those things that Pete just mentioned, and some others as well. And we have made great progress in a couple of those areas, and I'll tell you where they are. We are one of the best institutions in the country right now with regard to C. difficile nosocomial infections. We're probably in the top 5%. We're probably in the top 2% around surgical site infections for abdominal hysterectomy. we're probably in the top 10% with regard to central line associated bloodstream infection reduction. We're getting better, but we're not there yet in urinary tract infection due to Foley catheters. We're very much lagging in 3 surgical site infections: colon surgery, and hip and knee replacement surgery. Those are our 3 high priority areas. For each one of those infections, we have a very structured methodology where we have, every 12 months, we charter a team. That team has a sponsor, 2 chairs. It's got a staff that's multidisciplinary, and it's got an expert facilitator from the quality improvement group. They look at where we are with regard to our infections, where the gap is, how we're performing. They look at the process measures that are known to reduce those infections for each one of those. And then we put in the improvement plan. And I think some of you, I think Adam, had been on the County Committee for some time as one of the content experts, if I'm not mistaken. Still on it, thank you. But those are really important committees. And if you want to know how they function, we could get into detail. I'm sure Adam could tell you about how we really use this plan, do, study, act cycle, where we look at our process measures and we look at where we have gaps to, for example, in the County example, to pull those Foleys out at 48 hours. What are the things that are holding us back to do that? With regard to surgical site infection, we look at everything from hair clipping to standardizing our prep, to intraoperative normothermia, and so forth and so on. So please look at those numbers. If you're interested, get involved in one of those charters. We can happily put you on those teams. We've made a lot of progress. And again, our data, I put the numbers of infections, not the rates, in the medical staff bulletin every month, because I think it's important for us to focus on the fact that these are people. Rates are rates. Those numbers are actually individuals that are harmed because of things that we probably could do better. Every time that there is one of those infections, it's reported on a weekly basis in something we call the Hospital Adverse Incident Report, HARE. I'd be happy to send that to you. All the hospital managers and all the medical directors in the organization get that on a weekly basis. And the expectation is that we do an analysis, and that's driven by the nurse manager of that unit, of each one of those infections, and they have to report back every week what were the defects, if any, that caused that infection. So if you're interested, you can go up to the 4th floor of the Hunter Building. Rick Martinello, who's the Director of Infection Prevention and Hospital Epidemiology, he has a game board. He has a board about the size of that wall. He's got every unit in our organization. He's got the weeks. He has every infection tracked about what's the cause, and that data gets fed back to those committees so that we can make the changes to try to improve. Answer your question.
Yep. So, so some of the things we're working on, one is for office-based procedures. So we do several thousand cystoscopies and other procedures in the office a year, and there's really significant variability in our compliance with the AUA guidelines about antibiotic prophylaxis. So what we're working on is a protocol or a standing order set for the nurses to follow based on procedure risk factors and host risk factors for infection, which is going to streamline the process in the office for patients to get antibiotics, hopefully reduce variability and reduce infection. From a NPC or a Vizient and Northeast Purchasing Coalition kind of standpoint, we're working on hopefully decreasing our supply chain costs and making that associating that with quality improvements as well. So one of the things we worked on was decreasing our supply costs and the utilization project for ureteral stents. So we went from about an average cost north of $100 for a ureteral stent across our health system to about 40 some odd dollars. Which leads to somewhere in the 6-figure range of savings across the health system. But what we did was we tied it to tracking of the ureteral stents, because there are patients who have stents put in who then forget that they have them. And unlike a coronary stent, the ureteral stents have to come out. If they don't come out, they lead to infection and potential loss of the kidney. I think it was about somewhere in the first 2,000 or so stents we put in, we found 16 people who did not have their stents removed. So it was a nice way of showing that we can identify a savings initiative and tie it to a quality initiative at the same time.
That's a great example, Pat. And I think some of you in the room may know that Pat Kenny has an important role in our clinical redesign efforts here at the institution, because just like the effort that you just described, there are lots, we believe, of opportunities where there is alignment between quality and safety and savings. And as an organization, we have bet very big on the strategy that in order for us to remain very competitive in this very competitive environment with decreasing reimbursement, increasing technology cost, is to find areas of savings where that trifecta can be hit. And you know, we have literally hundreds of those kinds of projects ongoing, as Pat can tell you right now, where we believe there is opportunity to both simultaneously improve care and save money. But they must be driven by the physicians in the organization. All of these ideas, the vast majority of them, are coming from physicians because you all are the ones on the front line seeing where there is waste, where there's things that we can streamline. Not all of them are easy. I mean, you mentioned the supply chain initiative around stents. We just went through another round of supply chain initiative around standardizing how many hips we buy for arthroplasty across the health system. That going from 4 hips or 5 hips to 4 has netted us a $14 million savings, not without a lot of blood, sweat, and tears. Changing physician preference items is one of the hardest things we do. And one of the things that we've put together over the last couple years now is what's called the Clinical Governance Committee, or CGC. And you'll probably be hearing more about that. I'm sure Pat can give you the straight skinny on the CGC. The intent of that group is to get input from all the physicians across the health system when we are trying to do that standardization work at the health system.
Sure. So one of the other things that we've done over the past year is we established a departmental quality committee. And then it has 3 components. One is we have a data and analytics group that Mike Liebman runs. And what we're doing is we're tracking our own quality data using the surgeon value dashboard that was created by the clinical redesign group. And then we're also looking at NISQIP data and soon to be looking at our Vizient data for external benchmarking. We're using the second component, which is led by James Rozoff, is doing internal case review. So there are times where events happen or near miss or precursor event that may not be appropriate for M&M, but which is still worthy of discussion. And so we're reviewing those as a group and then providing feedback to the surgeon and then process change to try to reduce those events. And then the third component is taking that data and taking those case reviews and trying to lead quality improvement efforts, which Dr. Arlen is running for us. So we're currently working on a VTE initiative because our NISQIP data showed us that our VTEs are higher than expected.
We saw a lot of slides of what it's done. I mean, what is the vision over the next 5 to 10 years? Is it to continue expanding geographic reach, increase service lines? Are you focusing on inpatient or outpatient services? Kind of where do you see this going in 5 years from now as opposed to what we've done over the past 5 years?
It's a great question, and it is fluid, but there's some really kind of foundational elements. We are trying to focus much more thoughtfully on a higher level of integration than expansion of the system. I mean, it is not it's not anyone's intent to get bigger geographically. Our vision is still that there is plenty of opportunity in the state of Connecticut for Yale New Haven Health and Yale Medicine to have really strong clinical services. And that's kind of job one. So we're not, we're not in any way deliberately looking at bringing more hospitals on, and especially more bricks and mortar. The work is, what I alluded to earlier, that Pete and other clinical leaders have been working with us to kind of fully integrate clinical services. It's more important to us that SMILO, heart and vascular, urology, neurosurgery, all those clinical services have a standard across our health system, and they're all in kind of different stages of development. So, the short answer is we are now about integrating and making better what we have rather than collecting more stuff. Another big push is our ambulatory strategy, and there's been a similar effort to look at. We have over 100 ambulatory sites. We have everything from big boxes like Guilford and North Haven, to smaller centers like Old Saybrook, to one-offs here, there, and all over the place. And again, with the same group of chiefs and clinical leaders and the service line team, kind of looking at what should that network look like, and what is the look and feel and function of those centers. When you walk into Guilford, or you walk into Stamford, or Park Avenue Medical Center, how do they operate as a Yale New Haven, Yale Medicine enterprise? Everything from how you book, how you navigate, how you turn rooms over, what the facility looks and operates like, the phones, every level of detail that says that what we have is patient-centered and uniform across the system. Last thing I'll say is we are trying to be creative about relationships. You may know that St. Francis and Trinity Health, which is not part of our health system, is where Smilo operates their ambulatory cancer program. So when you enter St. Francis in Hartford, the nurses who are taking care of you and the physician protocols that are in place are Yale New Haven and Yale Medicine driven. We like more creative relationships like that. We are looking for things like that to expand, so that our signature and our service lines and our clinical services move north and throughout the state. That's some of the thinking that is really driving our thought process right now.
A lot of it is an outpatient strategy. I mean, the operating margin.
Well, it's both. Yeah, it's both. I mean,
why access? I mean, do you think where does your operating margin come from? Is it outpatient services, inpatient services?
It's right now about half and half. Yeah, you have to do both. You have to excel at both. You can't have just an outpatient strategy. And many of us expected that by now. I never thought in 2018 I'd be looking at a hospital with 95% occupancy. There was a lot of noise for decades about patients moving out of the hospital into ambulatory settings, totally disregarding the factors of demographics, aging of the population, and what we all can do to prolong life and wellness. And then what we've built collectively is this destination center that's still evolving, where the sickest and most complicated patients can only be cared for. Connecticut is a healthcare system. The smaller hospitals are almost like getting out of the business of inpatient care. What they were doing is moving to ambulatory sites. Think about same-day HIPs. That has left actually more of a residual of patients coming to the large centers, and us in particular, because they can't care for the complexity of inpatients that we have. So, I think we're seeing an environment where we will continue to be busy and actually maybe add beds in the academic medical center, push more stuff out to our system hospitals, do, for example, moderate complexity cardiac surgery at Bridgeport Hospital. We run that surgical program, so we can do more complex cardiac work and transplants here at Yale New Haven. That's directionally where things are going. Pete, I don't know if you want to add it to that, because you're part of that group, and you're driving it along with the other chiefs.
Just echo what Rick said. I think what we want to do is where we already are at. We basically need to do better integration. And I think we've done a good job in New Haven, but as we start to, lead out, we have 2 faculty members at Greenwich. We just hired 2 full-time faculty members for L&M this past month. So we really do bookend the state. They may be small programs, but we have Yale Medicine faculty in both those locations. And changing culture and creating an inclusive environment is not easy, but that's really what we need to do. With respect to the ambulatory strategy, I think I'm going to have, we just had a pediatric urology meeting last night, and we have, providers now or so, and basically, again, reaching from Greenwich up through New Haven to Old Saybrook, and then considering what we can do at L&M. But some of you would, Adam, just talk a little bit about some of the challenges. This is an opportunity, I think, for Tom and Rick to understand who have boots on the ground. What are we doing? Where we're doing it? What are some of our limitations? And a lot of this really touches on ambulatory strategy.
Yeah, I mean, I think for pediatric urology, we've actually had the model of satellite clinics longer than a lot of other kind of parallel adult settings. So we've been kind of traveling to the patients instead of necessarily bringing patients into the home nest for years. And it started with our expansion initially at Long Wharf, which was very successful, and kind of, partnered with other services and diagnostic services like radiology, which really created an atmosphere for residents where it was one-stop shopping. You'd come in and you'd have your diagnostic imaging and you'd have your patient care at the same setting, as well as a kind of multidisciplinary clinics. So I think that's really been very patient-centered because they can have all their care performed in one place. Plus, it makes it easy to travel. So with that success, the Children's Hospital expanded further west and went to Norwalk, and now even further, they're building a site at Greenwich. And with that expansion, we had a lot of leakage going to New York and leakage going to Boston. Those were kind of the main competitors. And we've expanded our outreach to kind of hold those patients in the state. So with recruitment, and Angie Arlen can kind of help explain some of the expansion going west and east, because we actually have her going everywhere that we can possibly go, since she has probably the most miles on her car. We've really offered opportunity to bring the services to the patients. And we try to parallel with services that we overlap with: nephrology, gastroenterology, endocrinology, and create multidisciplinary clinics that will then create the projects that I think make the magnet hospitals and these centers of excellence that really make you more competitive in these kind of big institution markets like Columbia and Boston, which are our fringes. So I think we've successfully started keeping a lot of those patients in by providing the services and bringing the services to the patients.
You're describing how, back to the previous question, how we need to evolve and be flexible and be thoughtful about where expansion takes place. Focusing on where
It would never have been possible if Peter hadn't promised to buy us cars and pay for our
never trust a promise like that from Peter. So.
Yeah. So So, in a small state, we have two children's hospitals, Connecticut Children's and Yale New Haven, within, an hour's drive, 45-minute drive. And they actually, in fairness, have been a little more aggressive about expansion than we have. So we have really built our expansion along the coastline going west and east. But they set up markets in our backyard. They went to Shelton and Fairfield years ago, and brought the physicians to the patients, trying to expand that, because that's where the better payer mix is. And they were still very effective in their expansion and controlling kind of the northern part of the state. So, to balance that, and we actually were trying to partner with them for a period of time, because there was some discussions about mergers of the Children's Hospital. There's a little bit of redundancy in the state. That conversation has been shelved for a little bit, but we have not effectively gone north as well as we could have. But as we started to expand and go west, we realized that we had this model, and I think some of what you were saying, you start with this plan to build, but we didn't understand all the variables. So we have competition from New York coming to Connecticut. So we were trying to balance that with our Connecticut bringing in New York patients. But we have some limitations on getting New York insurances. So some of the things that we just took for granted, we're going to set up along the coast of New York and going into Westchester, very strong payer mix. We're going to bring in a lot of New York patients, but pediatricians will have very mixed practices. So they're going to have well-insured patients and poorly insured patients, but they're not going to want to designate where they're going to refer their patients. But we had limitations on taking some of the state insurance and other kind of poor HMOs, and therefore had to say no to certain patients. Well, once you're saying no to half your patients, you're not going to want to send your other patients. And we didn't actually realize that was happening. And now we have this big investment in our practice and bringing on faculty in the hospital, building a site for patients that patients can't come to. So that was one of the roadblocks that we hadn't anticipated. We're partnering with the hospital and trying to work with that in Yale Medicine to address that issue. But we weren't as effective in bringing those patients in because we hadn't planned for that, whereas the other groups are really concentrating in those areas, and we're prepared for that because PUA, the example that Peter had given, is a group that's based out of New York, is already established in Connecticut, and is prepared to accept all the different insurances, but the overlapping geography.
there any other questions? Very quiet group. So Rick, I think this points to, and this actually kind of springboards off of what Tom just asked about, what's the strategy? And the strategy has to be taking what we have, clinically integrating, but at the same time beginning to understand the challenges as we spread with our ambulatory strategy in order to create that clinical integration. And what we're finding to be the case with pediatrics and adult, because now we're on the borders of both Rhode Island and New York, how do we bill? Because we cannot bill in Rhode Island as Yale Medicine, NEMG can, so we can
You can bill in New York though, right? Yale Medicine?
we think we can, but we can't accept some of the insurances from New York. Right. So unfortunately, as we sit on these borders, we're actually, unfortunately, strapped and not able to compete with those that can cross the border. So we're setting up, after last night's meeting, we're going to have a small working group that I'm going to put together that's going to focus just on pediatric urology on both ends of the state. And I'm going to bring together both people from the hospital, Yale Medicine, because we had so many questions last night during our discussion. We realized that the only way to move forward is create a subgroup with the appropriate people at the table so that we can begin to address this and have plans. Because one of the other issues is not having adequate bricks and mortar. So how can we leverage our ability to go into, because it's kind of a model to go in and lease space within a pediatrician's office and be able to provide urologic care to their patients locally, which if we could do that, that would be great. So anyhow, these are the things that we're all working on at a higher level, but I think it's an exciting time. We're almost out of time. I want to thank both Rick and Tom for coming. Have a great weekend, guys.
Thank you very much. Perfect.